Good morning or afternoon or evening. Uh, don't mind the mustache. It is November, and for Men's Health Awareness, a lot of people grow a mustache. We probably need to come up with a better way of raising awareness, but for now, this is what a lot of urologists do. I promise to everyone, including my wife, this will be gone in a few weeks. So I'm having you watch this video because we talked today about kidney mass or a concerning kidney cyst. You may hear a lot about kidney cysts from people you know. The vast majority of kidney cysts are benign and nothing to worry about. Majority of people over 65 years old do have kidney cysts, but there is once in a while a cyst that has an unusual feature that may be cancerous, or in the worst case, that it's a cystic mass where it's really a mass, it just has a bunch of cysts in it. And those all are kind of grouped into the category of kidney masses. So I do have a whole PowerPoint on this, and the reason being is that I've run into several issues with management in terms of confusion, where I counsel patients and I talk to them about the guidelines and the best practice for management of kidney masses and potential kidney cancers. And then there are some other providers and other specialties, uh, or even providers in urology that I have found, have counseled patients in ways that um, are not consistent with the guidelines and are not optimal care. They're not best practice. And so I kind of really wanted to outline, everything so that everybody's on the same page. Um, because my most important goal for the people in this area is that they get the best care possible and that they're not just getting what somebody convinced them to do. And if that's not with me, that's totally great. The issue is that there's very few operative urologists now in this area that do kidneys. Um, it was amazing. We had three guys previously, and we were all in the same practice. I've never heard of that, even in a big academic center. But now, I there's somebody new that came in, and I think that they do pretty good with kidneys. But then, other than that person, I'm the only person that regularly does kidney surgery, um, you know, 50 miles north and south. So um, let's go over the PowerPoint that I prepared. I want to make myself small. Uh, so here we go. So there are generally three types of kidney cancer. Okay, kidney cancer. However, 90% of the time when we say kidney cancer, we're talking about a type of cancer called renal cell carcinoma. There are two other entities that occur in the kidney that are malignant. They're lymphoma and transitional cell carcinoma, and they look very different. People a lot of times ask me, well, how can you tell, without a biopsy? It basically, one, looks like a sphere, which is kidney cancer or renal cell carcinoma, and the other two look like um, something that's kind of eating away, like moth eating. It's a mass that's kind of eating away at the kidney tissue. It's called an infiltrative appearance. And those are lymphoma and transitional cell carcinoma. And in those situations, I do recommend getting a biopsy if there's any chance that those entities are there, because the management is totally different. For lymphoma, there's no surgery indicated. It is medical therapy. It takes care of it, with the oncologist. So if you remove a kidney for lymphoma, that's like a totally unnecessary surgery. Um, and then for transitional cell carcinoma, there's a whole other management guideline. That's a much more rare tumor than renal cell carcinoma, where if you're going to do any sort of kidney removal, you end up having to take the kidney and the whole tube all the way down to the bladder, which is a more involved surgery. And we would want to know ahead of time if we had to do a surgery like that. But 90% of the time, we're dealing with renal cell carcinoma, and that's what this video is about. So I think we talked a little bit about biopsy just there. There is biopsy for kidney masses. And like I said, if it does have an appearance of an infiltrative tumor, I'll recommend a biopsy. But if it does not, most of the time, I will not recommend a biopsy, and here's why. For kidney masses that appear to be renal cell carcinoma that are spherical, basically, and they kind of a blotchy appearance. We call it heterogeneous. It's a blotchy appearance. 30% of the time, the biopsy is not useful. 15% of the time, the biopsy shows an undifferentiated result that they just stabbed you in the kidney, basically, and they don't have any useful information from that. And then 15% of the time, it's a false negative, which means that they're saying it's not cancer, but you actually have a cancer. And so those are kind of unacceptable rates to justify going ahead and doing a biopsy when the appearance is characteristic. So we run into kind of a situation where if it is safe to watch it, the best information we can get is to watch it and see if this thing grows. Kidney cancers tend to grow at a rate of 3 to 5 millimeters per year. So they grow slowly and they don't spread throughout the body until they're over a certain size. So this really kind of confusing graph shows how often kidney cancers spread per year based on their size. So you can see here for 2 centimeters or less, the chance of this spreading is less than 5%, really less than 2%. And then once you get over 4 centimeters for sure, now you're talking about 10% per year. There's a significant chance that this thing is going to spread and you really have to do something. There is definitely a discussion about 2 to 3 centimeters. I tend to intervene if it's between 2 to 3 centimeters, if it has a characteristic appearance. However, it would be totally reasonable to watch it in that you just do have a slightly higher risk of the chance of it spreading. And again, this is from one study. We have multiple studies that show the rates of metastasis based on the size of the tumor. Certainly less than 2 centimeters, it's safe to watch. It's a generally accepted practice that if you have a tumor less than 2 centimeters, if you want to watch it, that's totally fine. And generally, I would recommend watching them because that gives us this information that if it does grow 3 to 5 millimeters per year, now we know we are dealing with a kidney cancer and we're going to act and remove it before we get into this other area where there's much higher rates of metastasis. So if you're going to do something, there's generally 3 strategies. On the left, you can see this big blue ball, that's the tumor, and the dashes are as the removal of the tumor, and that's called a partial nephrectomy. And so basically you're just removing that part of the kidney. You take a little bit of normal kidney tissue in order to make sure you have a negative margin, and then you sew everything back up. However, if the tumor is overlying critical structures, that strategy is not possible and the kidney is not salvageable. So in the middle, we have what's called a radical nephrectomy, where basically the large vessels that go into the kidney are stapled and the kidney is removed. And then on the right, we have percutaneous ablation, or basically they go through your skin and stick a needle in it and do something to it. They microwave it, they RF wave it, they freeze it. There are several different modalities that they can do. They have similar results. RF has kind of fallen out of favor for microwave and cryo. But it is, you should note that cryo really is not recommended anyway, except for percutaneous, because it is truly minimally invasive, and that is the advantage. If you're going through someone's belly, like laparoscopic or robotic, it should not be cryo, it should be removal of the tumor, because now you're going into the belly, you have made that invasive step, and you should then go ahead and use that access to remove the tumor and not just freezing. But for patients who have difficult to access tumors or aren't very good surgical candidates and the tumor's less than a certain size, this percutaneous method is definitely an option. And then more recently, there's also another option of radiation, which really should not be performed unless the patient is definitely not a surgical candidate. Basic things to know about these surgeries. The first is that it seems counterintuitive, so I always point this out. It is harder, technically, from a technical perspective, to perform a partial nephrectomy than it is to perform a radical nephrectomy. The reason being is that to perform a partial nephrectomy, those big blood vessels that we would staple for the radical nephrectomy, I clamp them so there's no big bleeding while I'm cutting out the tumor. So I have to go and deal with those blood vessels anyway. Then I'm coming back, cutting out the tumor, sewing everything up. I have 25 minutes to do all that. And then I have to take the thing off of clamp. And kidney tissue is not the sturdiest tissue. So when you're sewing it up, there's always a chance that there's a tear or a rip, and you can have bleeding from that area. So you actually have a higher risk of blood loss with a partial nephrectomy than a radical nephrectomy, where you just come across those vessels, staple it, and that's it. The kidney's not going to bleed anymore. Another thing to know, ablation, where you go percutaneous and you just stick a needle in it, has a 15% chance of the tumor coming back. Whereas if you do a nephrectomy, either partial nephrectomy or radical nephrectomy, the chance of it coming back is 2%. And the other thing to know is all three methods, radical nephrectomy, partial nephrectomy, and ablation, have equivalent control of metastatic disease. Like, for example, so say you get this 15% chance and you stick a needle in it and it freezes, it comes back. You can then freeze it again, and now you have another 85% chance that it's not going to come back, and that's what prevents it from being metastatic. So that is why there is good data for going ahead and freezing it if it's less than a certain size, and that size tends to be 3 centimeters, which is why I generally don't wait too long to intervene once it's over 2 centimeters, because once it's over 3 centimeters, you just lost an option. And for a lot of people, it is a good option, especially if the tumor is in a really tough spot. It's way behind the kidney. So to operate on it surgically, it will be very difficult. It's less than 3 centimeters. For the percutaneous approach, it would be like a chip shot. Sometimes that's the best way to go, but if you wait too long, it's no longer the best way to go, and you've lost that option. So this is where I run into a lot of issues, and I have previously, with regards to some of the advice that my patients have gotten in the area. And that's regarding guideline management. So the National Comprehensive Cancer Network, say what you want about the federal government. One good thing, and definitely there's a lot that the federal government doesn't do well. One good thing that they have done well is they've created guideline patterns. And so for cancer, we have this thing called the National Comprehensive Cancer Network. And so what it is every doctor is, I don't know if you know this, every doctor is the best doctor. If you ask that doctor, they're actually the best doctor they ever met. And the way they do it is the way everyone should do it. And so to resolve these different combating philosophies of how to manage a certain thing, the federal government said, hey, look, we're going to give you an allowance. We're going to fly you all to Vegas. We're going to put you up in a nice hotel. You guys have to sit in a room and come to an agreement on what people should do with a certain tumor based on the evidence and your personal experience, fine. But you guys have to come up with some sort of consensus. And so that's where we get these guidelines. There's several different guideline committees. For cancer, the Bible is the National Comprehensive Cancer Network. That is the Bible, okay? So any discussion of cancer management starts with these guidelines, or should start with these guidelines. If you're going to go off of guidelines, you need to have a reason. And there are reasons. Not every guideline is perfect, but they're pretty good. They are pretty good. Okay. And so here are the National Comprehensive Guideline recommendations for the management of kidney cancer. Renal cell carcinoma, not transitional cell carcinoma, not lymphoma of the kidney, renal cell carcinoma. So you have on the left the stage. You have stage 1 for this slide. You have T1A, which means less than 4 centimeters, and T1B, which is greater than 4 centimeters, between 4 and 7 centimeters. And you can see for T1A, the preferred management strategy is partial nephrectomy. Then you could do ablative techniques, which is what I talked about, the percutaneous ablate when you go back through the back. Active surveillance, which is where we watch it. And I discussed all that. Really, you're talking less than 2 centimeters for sure. There's some debate between 2 and 3 centimeters. And then radical nephrectomy, and they say in select patients because if it's less than 4 centimeters, most of the time you're able to get it out without removing the whole kidney. Most of the time, the tumor isn't smack right where all those great vessels are coming in where the kidney's not salvageable. All right, so T1B, now that's greater than 4 centimeters, you partial nephrectomy or radical nephrectomy. Once it's over 4 centimeters, those tumors start to really, especially 6 centimeter tumor is really, there's a good chance it's now invading into the major parts of the kidney where the kidney's not salvageable. So you could do either of those. Active surveillance in select patients really means like not a candidate for any intervention. Now that's where you come into this radiation. Radiation may be a good idea for those patients where they're not even a good candidate to get anything done. It's already too big to do a cryo, and you can potentially radiate it. And that's the new footnote that I have here at the bottom, that stereotactic body radiation may be considered. Okay. And then or ablative techniques, again, really not recommended if it's over 4 centimeters by anybody unless you're stuck. Okay. And that radiation may be a better option now. Okay. So that's stage 1, stage 2, and 3. So stage 2 means really anything over 7 centimeters. Okay. And then stage 3 means it's invading into the fat around the kidney, or it's invading, into the vein of the kidney. And that makes it, or the lymph nodes, that makes it a stage 3. Okay. And the lymph nodes only around the kidney. If it's lymph nodes in the chest or something, that's a stage 4. So stage 2, stage 3, forget ablative, forget watching it. If it's not spread out, you should do something. And so partial nephrectomy or radical nephrectomy. And I just put at the bottom here the guidelines, the other set of guidelines that, I am required, okay, to be board certified to know and use is the American Urologic Association guidelines. And here it is, for radical nephrectomy, when you're going to remove the whole kidney. I just put this up here to explain why some patients we, don't do a partial nephrectomy. And, criteria number 1, if it's a high tumor complexity and partial nephrectomy would be challenging even in experienced hands. 2, there's no pre-existing chronic kidney disease. 3, there's a normal kidney on the other side, and you have a reasonable kidney function if you remove the diseased kidney. And then at the bottom, partial nephrectomy should be considered unless there are overriding concerns about the safety of removing the tumor through a partial nephrectomy. And that's when we get into like, well, it's invading the whole blood vessel. Like you can't really save the kidney. There's a safety issue. So that's kind of why we pick, partial nephrectomy versus radical nephrectomy. If you only have one kidney, you really kind of, and you're not already on dialysis or something like that, then we really, have to kind of pull out all the stops. And that's when we start talking about maybe we shouldn't use the robot. Maybe we should do an open incision and put the whole thing on ice. That gives you 4 hours that you can pick through and do what you need to do. And then maybe save the kidney, but it's a lot more to go through for the patient. Big incision, more blood loss. So these are the technical considerations regarding the actual mass. And that's why you need to have a surgeon that does all of these things so that they're not just, I have a hammer, we're going to use a hammer type of thing. I do this, that I use, you have to be able to use all the tools to figure out what is the best option for your particular tumor, because it is really individual in terms of where it is, how big it is, what's the shape of your kidney, what's going on with the other kidney, what's going on with your general health. You have to take all these into consideration when making these decisions. So again, this is kind of going over, partial nephrectomy versus radical nephrectomy. On the left, you can clearly see that's something that you can do a partial nephrectomy on. You just kind of core off the top of it. And on the right, you can clearly see there's no way that kidney salvageable kidney has to go. So that's how we make that decision. And then I'm just putting this up here because this is also a point of controversy. These are for stage 4 patients where it's spread already through the body. Please do not, if you've been told that you have kidney cancer and it's spread, please do not let anybody tell you that you should not have your kidney removed until you speak with a urologist who does kidney surgery. Because as you can see, the majority of these little arrows say nephrectomy. Well, half of them say if it's resectable, and so the M means that it hasn't spread. So for the top line, if it's resectable, if you can remove it, you should be removing it. But for the bottom line where it says M1, I wish I could, maybe I can do a arrow here or something. But do you see on the bottom where it says M1? Okay. If it's resectable, you should be performing a cytoreductive nephrectomy unless there's poor risk for the patient. So a lot of times we'll get a patient that has a couple of like lymph nodes positive and they have a big honking mass that's bleeding and stuff like that. That kidney should come out. Please don't just let an oncologist tell you no, you can't have that removed. It's gonna do you much better to get that thing out of you. So you should talk to a urologist who has experience with kidney surgery, whether it's me or somebody else. And you need to talk to somebody that you trust. So that's, I think, what I have for, the most important thing to know about kidney cancer, renal cell carcinoma, is that the urologist is the team lead if there is going to be any intervention. There are other specialties that get involved: medical oncology, radiation oncology, interventional radiology. But for any intervention, your urologist should be the leader of that team. And so you need a competent urologist that you can trust, one that can do all of the things, anything that's necessary, they can do that thing that I just showed you of all those options. And if that isn't here, then there's the cancer centers available: Moffitt, Miami, Shands in Gainesville. But the important thing is that you should have a urologist that you trust, that is kind of guiding the approach on how to deal with this mass. If you have, a radiologist tell you, oh, you should do this, the radiologist never sees you again. They have no idea what happens to follow up with the patient. They're not required to know the information on what happens to follow up with the patient in their boards. They don't go through any of this literature. The medical oncologist is better, but again, medical oncologists aren't surgeons. So you really do need a kidney surgeon to be the team leader on any intervention on your kidney. And that would be a urologist with experience in kidney surgery. So that's my spiel. I will have some individual recordings for this topic about partial nephrectomy and radical nephrectomy that you'll be able to view soon. And please call if you have any questions.